Uh, Good evening, everybody, and welcome to tonight's EEL webinar. This evening, we'll be discussing about the treatment with Relugolix combination therapy. Before we get started, we'd like to thank our partner, Moderator, who has been supporting this project for a while already, and therefore, please allow me to share short video of it.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission. What does it take to make a medicine? You need to shift.
All right. So now it's my honor to introduce our tonight's EEL webinar moderator, Tomaso Simoncini. He is full professor of OBGYN at the Department of Clinical and Experimental Medicine at the University of Pisa in Italy. He's the scientific director of the Molecular and Cellular Gynecological Endocrinology Laboratory, which is an international center of excellence performing studies on molecular mechanism of actions of sex hormones on vascular cells, cancer cells, and brain cells that are relevant to the diagnosis, prevention, and treatment of cardiovascular disease, cancer metastasis, and brain degenerative disorders. He also performs clinical research, particularly on the effect of steroidal drugs on endometriosis, on the role of fetal-placental nitric oxide system in fetal growth restriction or on preterm birth, on surgical techniques on pelvic floor diseases, on computer-assisted pre-surgical simulation of pelvic procedures, on innovative robotic surgical approaches to benign and malignant gynecological disease. He has published more than 250 original papers on high-impact scientific journal. From a clinical standpoint, he has extensively dedicated himself to the surgical aspects of OBGYN with a particular interest in pelvic floor reconstructive surgery, and also to minimally invasive laparoscopic and robotic techniques in gynecology, urogynecology, and gynecologic oncology. He's the past president of the European Menopause and Andropause Society. He's the executive secretary of the ISGE, executive secretary of the European Society of Gynecology, the board member and past executive secretary of the International Menopause Society. Professor Simoncini, it's a pleasure to have you here tonight.
Thank you so much, Alin. Thank you for inviting me here today. It's really a pleasure to be here chairing this webinar organized by the European Endometriosis League, which is a wonderful working group. And I think the topic that will be discussed today is really, really interesting. So it's the first time in a long period that we got new concepts for the treatment of fibroids, heavy menstrual bleeding, that change a little bit the paradigm and gets back in our clinical practice drugs that allow us to interact with the release of GnRH and with its efficacy on the hypothalamic pituitary ovarian axis by providing new possibilities. And tonight, it's really my pleasure to introduce the best possible speaker to approach this topic, Professor Ludwig Kiesel. Ludwig is a professor and chairman of the Department of Gynecology and Obstetrics at the University of Münster in Germany. And it's not just an expert obstetrician and gynecologist, but he's really an expert in benign gynecologies, fibroids, fibromatosis, and endometriosis. Ludwig is currently serving as the president of the Society of German Societies of Gynecological Endocrinology and Reproductive Medicine, and he's been involved in a number of working groups promoting guidelines on endometriosis, including the ASHRAE guidelines. So he's really a leading expert in this field. And in the past, I won't say how many years, because he's very young, and he's very handsome, though, as well. He's really been always on top on highlighting new molecular mechanisms, particularly relevant for the progression and for the biological consequences of endometriosis. So he's going to talk to us today about the Relugolix combination therapy by providing, I assume, new information on both uterine fibromatosis, but also probably introducing some new concepts that could be relevant for endometriosis as well. Professor Kiesel, it's really a pleasure introducing you, and the floor is yours.
Yeah, thanks very much, Tomaso, for these wonderful words. Especially after having such a nice Easter holiday, it is so nice to have all these friends, as I can see on the list, and I hope we can discuss it together, because we are definitely in need to improve our treatment modalities in benign gynecology, especially for fibroids and endometriosis. And today I would like to review mainly on the publications, what we know and what we have in hand. And I hope we still have time for discussing further details. Now, before I get into the studies, I'd like to just point out from a wonderful review I can recommend to read, and this is on uterine myoma, but some aspects may even be applicable to endometriosis as well, which I won't go into further details. But as you can see from this slide, fibroid, which is actually a very common but benign disease, as you know.
Professor Kiesel, sorry to interrupt. Could you please share your screen again, because it was me sharing my screen, and then.
Say again.
Could you please could you please share your screen again?
Okay, I can do that. Is it better now?
It's perfect, thank you.
Oh, okay. So you haven't missed much, because this is the first important slide. So you can see from this slide that in this common disease, there are a lot of risk factors we know already that will allow the change from normal myometrium or endometrium to fibroids, as you can see on the upper part. And there is a number of changes, mainly cellular changes and systemic changes, which will actually be required for these changes on a cellular level. And I think we need to understand more details on that in order to be able having better targets, just as in other diseases. Now, I can try to move the slides, and in order to understand what's happening, we can look at the simplified version of kind of an early hit on these normal cells, mainly normal stem cells. And these changes will result in reprogramming of stem cells, and a further hit will actually allow the tumor-initiating stem cell type. And as you can see from this cartoon, this is happening over several years. Now, there are also other factors which may change inflammatory reactions, and you can see a number of different risk factors which are listed here, which together may be increasing the likelihood to develop fibroids. And that's a very common list of risk factors, we all know. And I think that's probably one of the reasons why these fibroids are so common in women. But of course, fibroids can be different, and we need to understand more about it. So we have to understand what we'll do as a treatment modality for fibroids, and I will call it myoma for the simplicity. And I know that you are fully aware that we have got at least 3 groups of treatment modalities, ranging from medical, surgical, and radiological interventional type of treatment, and they are mostly complementary in a discussion with patients. So we all know that we need to have a wide range to individualize treatments. And today, of course, I will concentrate more on the medical management, because often women ask, can we do something else than surgery or intervention? And of course, that's what they feel a bit more comfortable about, but we need to know more details about it. Now I will briefly revise for you the two studies, which are actually duplicate study, using the GnRH antagonist, Relugolix. And the new modality is that it's an orally available drug, and it is a combination. And because we all know from the whole GnRH agonist trials that we need some kind of add-back. And this is a fixed combination, and that's what we're going to talk about. But first, I'd like to show you how we get to these results and what can we expect from using this drug. Now, these two trials called Liberty 1 and 2, they are basically the same trials, two separate trials, which is basically required by the FDA for all the bigger studies. So these two trials have an inclusion criteria for women. First of all, UF meaning uterine fibroids, uterine fibroids shown here, and heavy menstrual bleeding. So these are the inclusion criteria, and I will show you a bit more on that. And the endpoint, or the primary endpoint, is to have the responders who will actually have a reduced menstrual blood loss. Now, interesting part is how this study has been carried out. First of all, it's a placebo-controlled trial, which is very important. And second, it's the combination therapy, Relugolix. And third, there is a different arm, which is using first just Relugolix alone for 12 weeks, and then the combination therapy. Now, one would ask, why would you do this if you are having a combination? Now, there was an idea that possibly you can actually have a more intense action by Relugolix alone, and then ameliorate some of the side effects by adding some steroids, and that's why the combination therapy comes up in the second part. So basically, what we're talking about today is this three-arm study of placebo, combination therapy, and this kind of a delayed adding of a combination therapy. So over the period of 24 weeks, other secondary endpoints was looked at, such as amenorrhea, as you can see on that slide. And these are the usual methods to understand bleeding disorders, pain, the size of fibroids, the size of the uterus, but also to look at the endpoints of safety. And this is obviously a very important question because we have some experience with other GnRH analogs. And as you can see from here, I will go into several details in order to be able to counsel patients on these aspects. Now, the inclusion criteria, as I showed you before, is women below the age of 50 who have confirmed uterine fibroids on transvaginal ultrasound. And it has a list of different types of sites, but also the full size of fibroids could be an inclusion criteria. So if you add up the different volumes, it has to be a certain amount as shown here. And also it had to be a certain amount of bleeding. As you know, 80 is regarded as a kind of a norm or a median of for women per cycle. And if you have this twice as this amount or more, this is 160 ml, and that was an inclusion criteria, or you had two cycles with more than 30 ml. So these were the inclusion criteria. Now I will jump right to the results. As you can see from this slide, you comparing just the two arms, and this is placebo and Relugolix. You can see from here that over the period of this treatment, you can see demonstrated here that the proportion of women responding below 80 ml, which means if they had more than 160, how many women actually had improved heavy menstrual bleeding. And as you can see here, there is some improvement to placebo, but there is a large improvement in both study arms, which are the same studies, but carried out in different countries. And if you want to look in more detail, you can see here on the right, the control is on the top with placebo, and here's the two studies with the two lines with the combination therapy of Relugolix. And you can see over the period of time from baseline over 4 weeks until 24 weeks, that you have quite a rapid drop of blood loss, and that's already occurring by week 4. So it seems that this method works. And of course, we're interested how we can achieve amenorrhea, especially in women with heavy bleeding. And this is one of the aims. And you can see from here that about 50% of women will have amenorrhea. And these are the women who were looked at in the last 35 days of the study, which means at the end. And it is basically the same in 2 study arms. And throughout all these endpoints, there will be no major difference between the 2 studies. So the second study is kind of a repeat. Now, if you look at hemoglobin levels, similar results, you can see an improvement. And there may be a little difference between the two studies, but there will be a significant improvement here, much better in this study. I won't go into the reasons for that. The important factor was to have an increase of more than 2 grams per deciliter throughout the study. Now, of course, myoma can occur also together with pain. So we are interested to see, does actually pain reduction occur? And if you look at the scoring system, you can see that you have a range between 40 to 50% will have a significant reduction of pain, which is associated with uterine fibroids in both studies. So the symptoms actually decrease, and you can see this occurs already at week 12, and it's a little more pronounced at week 24. So the symptom improvement you can see here. And it's always interesting to follow what happens to the placebo, I think, because this can also change, as you can see from here. And as usually with studies in many other areas of hormone treatment, you do have some placebo effects which have to be taken into account. And that's why I think it's important to have placebo-controlled studies. Now, we are very much interested to see what is reported by patients about their health-related quality of life. And this is basically what's shown for the 2 studies. And you see from, again, gray columns being the placebo group and the orange for the treatment group. And throughout the entire list of these factors which are being looked at in this quality of life questionnaire, you can see that in most of these have a really remarkable effect on a better quality of life. And that's, I think, is very important, not just looking and measuring certain aspects of changes, but also what patients report as changes in quality of life. Now, having said that, we still are looking at something we can actually measure, and this is something we are very much interested in, to see uterine fibroid volume and also uterine volume itself. So uterine volume itself is definitely changing to some extent. uterine fibroid volume can be different. As you can see here, there are some changes, or there is a trend, but it's not always significant. So the fibroid volume is not necessarily changing to that extent, whereas uterine volume is actually changing more significantly. Now, using GnRH analogs has been always paralleled by several different adverse effects and events. So we are, of course, focusing on something which can cause to discontinuation, and that has been happening with GnRH agonists, as you know, especially if you don't use ADBAC, and that many patients discontinue, and nowadays that's even more pronounced. So if you look at the numbers, discontinuation rate is rather low, somewhat higher if you delay the combination therapy, which means initially you only have GnRH antagonists, and of course you have the more severe symptoms. So patients have a higher rate of discontinuation. And if you look at the adverse events, you can see from here, of course, hot flashes is something we are very much interested. And it seems that this is occurring to some extent, both in placebo and in the treatment group, and of course more pronounced in the group where you don't give ADBAC in the first half of the treatment. So that's obviously something you see with GnRH agonists, even at much higher rate, because in the second part they have already ADBAC in that group. So there is a definite difference in delaying it. And as you've seen from the slides, there is basically no good reason to do that. And there is no big difference between the group of placebo and the treatment group. And so that we can be quite happy using that. And something which is often looked at is headache occurs, of course, in many women at different stages. And throughout the entire period, you have about 10 to 15% women, and but in some study arms like the delayed part, you even have even higher rate. But this is not different placebo or treatment group. So at least in that study, that doesn't seem to be a problem. Now, an important factor, of course, is bone, as you can see from here. If you compare the use of GnRH antagonists and the control, there is no big difference, and it's not significant. And it is looked at lumbar spine, which is, of course, important part for this for the bone. And you can see, sorry, I think I haven't looked at this. And the same is actually also from for other parts of the bone as well. So if you summarize this part, which is the 6 months period of treatment, you can see that there is a definite improvement of pain and hemoglobin levels, but also improving patient-reported outcomes, which is important. But mainly, of course, the reduction of the loss of blood within the 6 months of treatment. So there is definite improvement. And so there's a clinically meaningful improvement of blood loss compared to placebo. And as I've shown you, it is a well-tolerated combination therapy. Now, the idea is, of course, to use it for longer term. So there is a different clinical development program where you extend that treatment period to 52 weeks in order to see what's happening further on if you carry on treatment beyond 6 months. So this is the so-called Liberty 3 trial, which is patients who's been taken from the 2 different arms of the study and adding it to one treatment. So as you see from here, the placebo group initially having received placebo, and then after the 6 months, they also get Relugolix combination therapy. So in the end, all 3 arms have the same treatment, for the 52 weeks after 6 months. So we were interested to see what's happening to blood loss and how many patients will actually have more than 50% reduction. And as you can see, they're about similar once you have all women treated with this combination therapy. Possibly the combination therapy right from the start is more has the highest proportion of responders. And also, if you look at amenorrhea rate, that's quite similar. Now, if you look at the different weeks, you can see that the randomized treatment, which was for 6 months, I have shown you before. So you have the controls with the placebo, and you have the 2 treatment arms. And after 6 months, all the groups will have GnRH antagonists. So in the end, they will have the same effect, and the blood loss reduced by 90% after 52 weeks. So that's quite a remarkable reduction. And if you look at the clinically meaningful increase of HP concentration, hemoglobin will gradually increase. And as you can see, the 2 arms which had GnRH antagonists during the randomized treatment have quite a good increase of hemoglobin. And also the placebo group, initially treated with placebo and receiving GnRH antagonists thereafter, will gradually increase. So this is a good demonstration of the effect of anemia treatment in these patients. And we are, of course, interested to see if there are any further additional adverse events occurring. And luckily, there were no big difference. And I think maybe headache, since it doesn't occur in the same patients all the time. So if you add up in different patients, you will have a little higher rate than in the first 6 months. So over a period of a year, you probably have a little higher rate of headache. But as you can see from here, for example, placebo group had a lower rate initially, and it will actually catch up later on. So after Relugolix treatment, they are all about the similar level. Now, important thing is what happened in the bone and long term. And if you look at the different results, again, placebo being here on the top, and this not much change because there is no GnRH antagonist. And also here you can't see a change. You can see a change with Relugolix alone initially. So that's what happens if you start with GnRH antagonists without add-back therapy, and that's with add-back therapy. So there will be basically, in the end, if you use GnRH antagonists in a combination, you have no difference from placebo, even after 52 weeks. So if you summarize the study period for 6 months, plus also the new data on a year study, you can see that there is a really significant reduction of menstrual blood loss, patients with reduction of pain, improvement of anemia, and also a well-being of patients. So that's something very important for patients to understand, that they will have a better quality of life having this treatment, and there are no relevant safety concerns, especially not on bone. So I think this will give you some overview on the uterine action on uterine fibroids, and I'd like to add some new data also looking at endometriosis, and I try to summarize for you a publication, especially looking at treatment of endometriosis by medical agents. So here's a list. You know well about the present modalities for medical therapy. And of course, I'd like to summarize the GnRH antagonist Relugolix work for these patients with endometriosis. So this is a study which is now called Spirit. This is again a Relugolix combination therapy, as you've heard before, for the fibroid work. You see these data on women with endometriosis-associated pain. And this is a phase 3 study again, and it is again a double study, which means you have Spirit 1 and Spirit 2 as a study. And for those of you who'd like to read the data, you can see this data. Here's the first page, and you can look it up, the full details if you like. The first author is Linda Judice, with a range of well-known experts of endometriosis. And the study has been carried out in different countries, and the two studies will be shown as Spirit 1 and Spirit 2. Now, again, you know the study design is very similar again. It's placebo versus upfront GnRH antagonist plus add back Relugolix combination therapy, or you have 12 weeks of Relugolix and then the Relugolix combination therapy. So you have quite a large number of women in each of these studies. These are two very similar studies carried out in different countries, and the co-primary endpoints being the proportion of responders based on the dysmenorrhea score, and also women who are responders based on non-menstrual pelvic pain. So you can see from that, these are two quite different aspects. One is mainly related on the menstrual problems, and the other one is non-menstrual pelvic pain, which I think is something very important, because this may be a bigger group of women, and of course we know that non-menstrual pain can be multifactorial. So I will try to quickly summarize the whole findings. Different scoring systems have been used for these pain scores, and for those of you who are interested, can look this up. And there are different criteria for dysmenorrhea, non-menstrual pain, overall pelvic pain, dyspareunia, and these are important factors. And also this EHP 30 pain domain score. So there are many different aspects to look at that pain. And again, the two studies, Spirit 1 and Spirit 2, there was some difference on that, because there is a proportion of patients not using analgesics, and also some with analgesic use in Spirit 2. So here again, Spirit 1, this is the one study which is shown here. In the end, the three study arms had around 180 patients each. And the same with Spirit 2, this is almost the same study as shown before. So the demographics is quite well known. You can look at the race, for example, is mainly white, but some percentage of Black patients and different geographic regions. Some of it is in North America. You can see from here that is different in Spirit 1 than Spirit 2. There's a different proportion, and Europe has a major part in Spirit 1, but also in Spirit 2 and other regions. So there is some difference between the two studies. Now, one important factor, of course, as you know, the numeric rating scale, in order to understand and ask patients the amount of pain they experience. So important here is that moderate pain of 4, which is the basis for entering that study. And of course, the range is, as you know, from 0 to 10. Now, the data here, both for dysmenorrhea and non-menstrual pain. So we do have these two aspects, dysmenorrhea being linked, of course, to the menstrual pain. And you can see from here, interestingly again, that placebo is quite remarkable, but dysmenorrhea pain, cycle of pain, is improved in 75 or 72% of women in Spirit 1 and Spirit 2. So in both study groups is almost the same. And these numbers are about the same as the women who do not experience any regular menstrual cycle. So that is, of course, linked to that. Now, the more difficult part, of course, is the non-menstrual pelvic pain, which is a kind of a whole list of different causes of pain. Now, you have some effect here too, but interestingly, you have a high percentage already with placebo, which it can change. These are pelvic pain, which can occur independently of cyclic pain modalities. And you can see some changes or some improvement, but it's definitely not the same as with the cyclical pain. And you can see there are some differences between the two studies, but the trend is about the same. Now, if you look at more these and the endpoints, more of the co-primary and secondary endpoints. First of all, the co-primary endpoints, the two major points, as I pointed out. You can see here the numbers, but I have shown you that before. I think it's interesting to see the secondary efficacy endpoints that you have in this questionnaire, where you can see the patient-related or reported problems here quite well. And you can see different types of pain. And also you can see the differences between the Relugolix and placebo. So I think this is an important column here, where you can see the changes. Some of the pain types change less than others. So you can see, especially in that group of reported pain, that can be differences. Now, just looking at one more detail, again, you can see that in this scoring with EHP 30, it's kind of well-known rating, and it's a kind of 30-item questionnaire, which can define the different problems of life quality, which is related to different abilities to stand, sit, walk, and exercise, and also sleep, and also social events, job, appetite, etc., which is related to these problems. So you have a good effect with the GnRH antagonist, but you have, of course, some effect on placebo alone, which is quite well known. So again, on the bone, we have seen that, some of it before. You can see the differences. There is basically no big difference between placebo and the use of GnRH antagonist combination, and there is a somewhat drop if you delay the combination therapy. So you need some add back in order to prevent bone loss, as shown before. And on the hip, it's about the same. It's a little less changes, and it's quite reassuring that you don't have a remarkable change. And this is over a period of 24 weeks. Now, adverse effects, again, are important. And as usual, we look at things like headache. Headache is quite common. It's between 20 to 30% here. And it's quite similar in the different groups. Interesting in nasopharyngitis is often reported, and the causality is a bit difficult to grasp. And hot flashes are, again, the same thing as I showed you before for the fibroids. You have, with the delay, of course, a higher percentage. So basically, if you go through the whole list, there's no major difference. And so the conclusion, again, is that you have quite a good effect on dysmenorrhea, of course, and you have about close to 45–50% change in the cyclic pain, but also some effect on non-menstrual pelvic pain, which is around 19 to 23%, and this is significantly higher than with placebo. and it's well tolerated, and the common adverse events are usually headache and hot flushes and nasopharyngitis. So again, this is a reasonable way to address the medical treatment by just administering once daily, and you have a fixed combination, so you can't change the composition of this combined therapy. But again, it helps you because you don't have to figure out which treatment modality and back you should use. So I think it helps you to see how we can use differential GnRH antagonists, and this photograph just shows you where I'm sitting now in Münster, being the center here, being the old part, and outside the center we have our hospital center, and welcome you to come to visit us. So I hope you got some ideas for the use, practical use, and looking forward to your questions.
Thank you so much, Ludwig, and thank you so much, Professor Kiesel, for this wonderful presentation. You made a wonderful case in presenting all the data from the Liberty trials to this new Spirit trial, which I think really highlight how powerful this combination can be. I'd like to remind everybody who's listening that any question you want to ask, please write it in the chat. Okay, so we can see the question and Professor Kiesel can then answer. So I'd like to start off with one very clinical question, Ludwig. And so maybe to raise the curiosity before starting with the questions from the audience. Can you tell us from a physician's, from a clinician standpoint, how do you envision the clinical role, the clinical niche of the Relugolix combination therapy compared to the previously available concepts? I think we've been very much used for the past 20 years now to use progestin-only pills liberally in both in women with fibroids and in women with endometriosis. For some progestins, we have very good evidence of efficacy in terms of decreasing endometriosis activity and pain. And so what's the shift? So how one would choose a patient for a progestin-only pill as compared to the Relugolix combination therapy?
Yeah, I think, Tomaso, you got the right first question about how can we compare the different treatment modalities. And I've shown you, let's say, for example, for endometriosis, as you mentioned, we have a whole list of different types of agents. And from the perspective of price and application, of course, progestin only are commonly used, but also, at least in my practice, we have quite a number of patients who do not take it because of side effects. And this is probably the main reason to look for other things. And I think we cannot fully answer the question because in these these studies, we do not have a head-to-head comparison of progestin only and GnRH antagonist combination. So we actually have just a comparison to placebo. So all I've shown you that there is a good way to use it in those patients who would like to have a long-term treatment without any, I would say, side effects, which are typical for progestin only. So in my practice, we have that problem of progestin-only side effects. So you need to have different applications. My guess is that, of course, due to financial reasons, and there will be, of course, some trend to use those drugs first, which are not expensive and more affordable. But you still have to have a wide range of application. And I personally think that these studies have shown quite well side effects are not a predominant problem of that treatment modality. So I would personally think that's a good niche for treatment of both for my fibroids and endometriosis. So I personally think that will have a place. But of course, we have a full range of other drugs which, according to preference of healthcare providers, will be used also.
Thank you very much, Ludwig. So we have a couple of questions in the chat. So let me start with one which links directly to what you just commented. That comes from Professor Senturk from Levent, from Turkey. He's asking if you could comment on the costs of this combination between Relugolix, estradiol, and levonorgestrel, and compared to the levonorgestrel IUD, for instance. So is it going to be quite expensive? How is the market moving? I know that this is still under registration for cost in different countries in Europe right now. Yeah,
that's a problem. I'm not able to give you the list of prices. So I think Gedeon Richter will be able to provide you the local prices. I mean, of course, these agents, let's say Relugolix combination therapy, obviously having 3 drugs in one application. So you have the GnRH antagonist, you've got estradiol, and you've got norethindrone. So it's so per se it will be higher than using progestin only, which is for sure. But as I said before, there is a different. If you compare it maybe to intrauterine devices, that may be different. It depends how you compare it. But costs are obviously for new drugs generally higher than previous ones.
Yep. There was a question on bone coming from Dr. Piriev. The question is, if you, given the data that you have shown that the trials don't show a major progressive loss in bone mineral density, but anyhow, some very slight decrease is seen at least after 52 weeks. So the question is, in case one uses the Relugolix combination therapy for a long term, for instance, 52 weeks, like in the trials, should you do additional measurements of bone mineral density with bone densitometry? Would you advise that?
Yeah, if you use the upfront Relugolix combination therapy, you don't need to measure bone loss after 52 weeks. Of course, if you extend it for several more years, of course you can do it, because if you add up, you probably will get some change. But if you compare it, for example, these are generally, let's say, in these endometriosis cases and also in the fibroid cases, if you compare it to bone loss, for example, under other circumstances, let's say if you have a postpartum period, you have after 6 months, you've got a drop of at least 5 to 6%. But this doesn't really matter in young women. So clinically, it's not relevant. Of course, on long term, if you would have it for several years, I would advise to do that. Because in some women, you may have higher than others. So as you know from studies, you always look at averages. So average means, of course, there's a big difference sometimes for others. So I would advise after some years, let's say after 2 or 3 years, to do it and to see it if this is somebody who is probably losing more bone. And I personally use it because if you have women who have a rapid bone loss under these treatments, even with that back, if these are the ones, women who are more prone to bone loss in the post-menopausal period. So I think this is a little help because otherwise you don't have this kind of a test. It's not meant to be a test per se, but you can actually use it once you select women who have a endocrine-dependent bone loss more than others. So I personally would do that, but it's quite early to say it because we haven't used that for such a long time. So there's a not long-term general clinical experience but looking at the numbers, you would be able to, I think, to say that or predict that loss over many years in some women.
Thank you, Ludwig. There's a question from Professor Krentel, who actually notices that, of course, the current German endometriosis guidelines identify Dianogest as the first choice treatment for endometriosis. So the question is, how would you include the new Relugolix combination therapy if you had to rewrite the guidelines? Yeah, I'm sure you will rewrite the guidelines because you're always working on these suggestions. So would it be first line, second line? So would there be any reason on why choosing one versus the other as a starter?
Well, first of all, in the guideline, these data has not been included fully in that guideline. So I think we have a problem of relating it just to the guideline itself. But Professor Krentel is right that the use of Dianogest, which has been developed in Germany initially for other purposes, but it's been fully used now, and it is also licensed for the use in endometriosis. So it is per se something you can actually prescribe. It is not off-label. So if you prescribe other hormone treatments, they are often off-label. So that's something which is already ongoing. So Dianogest treatment, and it is at least in most countries, Dianogest therapy is cheaper. So that's why I think in many countries it will be one of the main reasons, even if Dianogest is not more potent than Relugolix combination therapy. But here, the same thing applies, as I said before. I've got quite a number of young women, and that's the second part of Professor Krentel's question. What about the age dependence of the use? And I think this is very important. If you have women who are very young, they're often sensitive to these Dianogest treatment side effects. So it's, of course, I'm very biased because I'm in a center where all these patients end up with these problems. So I do see a lot of them, but it may actually not be so high if you look in the general population. So I personally think that in young women, probably Dianogest treatment will be high, with a high side effect rate, or higher than in the elder age. And then the second point is that if you have women who are close to menopausal age, if you use GnRH analog treatment, you will be able to postpone surgery, or actually even you don't even have to do it anymore. And I think this is certainly age-dependent use. And young women, of course, you will go through to different type of treatments because there is treatment resistance, of course, as we know. And so you end up having different type of, and that's why I think in the moment, I think Dianogest is very commonly used, but Relugolix therapy could have a similar effect, so maybe as on the same level. But maybe due to cost, there will be maybe a preference to drugs which are less costly. And
Ludwig, I have a personal question on which is a little bit speculative, so I don't expect you to have an answer, but maybe ideas or opinions. So whenever we give a long-term treatment, be it for fibroids or be it for endometriosis to a woman, we tend to modulate the amounts of estrogen she has available, particularly when we use progestin only. Dianogest, of course, we do know that blocks ovulation, although not completely, but there's certainly a decrease in the available amounts of estradiol. And now with the Relugolix combination therapy, we basically completely block ovulation thanks to Relugolix, and then we provide 1 milligram of estradiol, which is considered to be a low dose estradiol hormone replacement therapy, even when given to 50-year-old woman. So do you have an idea on how it compares in terms of the estrogen blockade or estrogen reduction in terms of exposure to women who are particularly in their younger ages? So do you think this would make any difference in the long term? I know the data, you've shown the data that are reassuring in terms of bone loss and side effects, and that's absolutely reassuring. But, you know, I have a concern that this could be a little bit low.
Yeah, there were these clinical initial phase 1-2 studies have looked at the different rates or levels of estradiol. And the main aspect that in these benign modality treatments, you have actually the aim of having a kind of a mid-low or mid-high level of estradiol and unchanging throughout the cycle. So that's the aim. It depends how you look at the amount. The total amount may be somewhat lower in the total amount. And you will have, of course, the main range is at the mid-normal range, but you don't have this high rate. So in the end, if you try to compare the different levels on, let's say, on a monthly basis or something like that, you may have somewhat lower level, which is attempted in order to have a treatment effect. That's the idea. And so I think you have some little change, but it's not so significantly lower. Again, it is a mean level or a median value, so you will have differences on the action of this drug, and there is of course differences between different women, so you can't totally generalize this effect, as you said.
Okay, thank you so much. There's a couple of comments in the chat. There's a couple of persons who actually comment that they don't see major advantages over or cost effectiveness compared to other GnRH, for instance, GnRH agonists or progestins. But I think you've commented on that, and I think you've explained your vision on the possible niche, and I agree that cost is only a part of the problem. Cost is always a problem when we introduce new drugs. The real importance is really finding what of an additional use these drugs and these combinations can give us. And the more we have in our armamentarium, the best physicians we can be and the more effective we can be in treating different and complex conditions. So I think we are near to closing because it's 8 o'clock, at least in my country. So giving the word back to Arlene Constantine, and I'd like to, before doing that, thank again Professor Kiesel for this wonderful lecture and for the very nice discussion. Thank you, Ludwig.
Thank you very much for moderating.
Thank you to both of you for being here tonight. Thank you for the presentation and excellent moderation. And we also thank our sponsor, Gedeon Richter, for supporting this project. So thank you, everybody. Have a nice evening, and we're looking forward to have you here next month.
Thanks.
Bye-bye.
Bye-bye. Have a good night.